For patients with small fiber neuropathy, the sensation usually begins in the feet as a severe burning or numbness that slowly creeps upward. Under the skin, the affected nerve endings physically shrivel and retract away from the surface. The primary structural pathology of the disease is the degradation of C fibers and pull away from the epidermal layer. Clinicians track this decay by measuring intraepidermal nerve fiber density. This diagnostic metric calculates the exact number of nerve endings successfully crossing into the outermost layer of the skin. When patients present with severe fiber loss at major research hospitals like the Cleveland Clinic, the treatment options are restricted to managing symptoms. The standard pharmaceutical approach relies almost entirely on strict blood glucose control and the administration of neuropathic pain medications, primarily gabapentin. Gabapentin operates by suppressing neurotransmitter release to quiet misfiring pain signals. It does nothing to halt the physical retraction of the nerve endings. The structural collapse of the fibers continues beneath the masked symptoms. Because the medical establishment approaches the condition as an irreversible structural collapse, researchers have looked outside standard symptom management for a cure. The most viable strategy for regeneration relies on target-derived neurotrophic factors. These are specialized proteins secreted by target tissues that instruct connecting neurons to survive and grow. The primary candidate identified in the literature for sensory nerve rescue is GDNF, or glial cell line-derived neurotrophic factor. GDNF specifically binds to receptors on sensory neurons. This binding activates a biochemical signaling cascade that stops cellular decay and triggers axonal rescue. Despite its clear mechanical potential, GDNF has a documented history of severe clinical failures in human trials. The failure stems from how the drug is delivered. When GDNF is administered systemically or directly into the spinal fluid, it indiscriminately bathes every organ system in the body simultaneously. Because GDNF receptors exist throughout the body, this systemic flooding triggers massive off-target cascades. Trial patients suffered from acute muscle pain, anorexia, and peripheral edema. This brings us to a specific small molecule known as XIB4035. When applied topically as a cream to mouse models of neuropathy, XIB4035 successfully treats the condition without any of the toxicity seen with GDNF. The established literature on this molecule classifies it as a direct GFR-alpha-1 receptor agonist. An agonist is a chemical that binds to a receptor and independently activates it, meaning XIB4035 is supposed to function exactly like GDNF. This creates a pharmacological contradiction. If XIB4035 independently activates the exact same receptors as GDNF, it should trigger the exact same cascade of systemic side effects as it absorbs into the body. The complete absence of systemic toxicity suggests the foundational literature classifying XIB4035 as an agonist is incorrect. To prove how XIB4035 actually works, researchers had to test its ability to activate receptors in a controlled in vitro cell assay. They used human neuroblastoma cells, specifically the SHY-S5Y line. These naturally express the GFR-alpha-RET receptor complex, which is the exact biological hardware targeted by GDNF. The rules of this test are strict. A true agonist must bind, independently trigger phosphorylation, and start the repair engine. This chart shows the assay results. When researchers applied GDNF to the cells, TH promoter activity spikes, proving the receptor is active. But look at the data for XIB4035. When applied completely on its own, the result is an absolute flatline. Researchers also gathered supporting biochemical evidence from anti-phosphotyrosine Western blots. This technique detects the physical presence of phosphorylated RET receptors. The blot confirms the absence of activation. GDNF produces dark, distinct protein bands, while XIB4035 yields completely empty lanes. This raw biochemical data disproves the published literature. XIB4035 is biologically incapable of activating the receptor independently. If the molecule does nothing by itself, the next step is to observe the dynamics of co-treatment. Researchers administered XIB4035 simultaneously with naturally occurring endogenous ligands, like GDNF or artemin. The results showed an immediate, startling observation. The dose-response curve shifts dramatically during co-treatment. This line graph shows the concentration required to trigger a cellular response. For GDNF alone, activation requires a minimal dose of 75 picomolar. But when XIB4035 is added, the required dose plummets down to just 2.7 picomolar. This proves a massive multiplier effect. The molecule forces the cell to reach maximum biological response using a fraction of the required ligand concentration. XIB4035 does not start the signaling engine itself. Rather, it acts as a massive pharmacological force multiplier for ligands that are already present. To understand the physical mechanism driving this force multiplication, we have to examine the kinetic data. The most important metric here is the duration of the PRET phosphorylation signal over time. This measures exactly how long the receptor stays switched on. Under normal conditions, a standard GDNF-induced phosphorylation signal degrades and returns to baseline within 60 minutes. But look at the anomaly in the co-treatment data. XIB4035 drastically prolongs that active phosphorylation state well beyond the 60-minute mark. The endogenous ligand binds to the receptor first. Then XIB4035 inserts itself, physically locking the entire complex into a rigid active state. The sequence of events is strict. The naturally occurring ligand must find first to create the correct physical geometry. Only then can XIB4035 attach. Once attached, XIB4035 acts like a molecular clamp. It prevents the ligand from detaching and artificially extends the active signaling phase. Based on this mechanism, we can redefine the molecule's pharmacological classification. XIB4035 is not an agonist, but a specific positive modulator. Because it is a positive modulator, XIB4035 remains biologically inert and harmless unless it encounters a receptor that is already naturally engaged with a ligand. Translating this modulator discovery out of the petri dish and back to the physical reality of human skin explains why topical application works so well. Within the lower layers of the epidermis, specialized skin cells called basal keratinocytes naturally secrete endogenous ligands like nurturin. Applying the drug topically exploits a topographical advantage. The cream delivers the modulator exactly to the skin layer where these endogenous ligands are already waiting, causing them to instantly activate the receptors on the damaged nerve endings. This creates a built-in safety mechanism. As the drug diffuses deeper into the bloodstream, it remains entirely inert because those deep tissues lack the required endogenous ligands. This precise ligand-dependent spatial restriction stands in contrast to the blunt force toxic receptor activation of previous systemic GDNF therapies. In murine models, this approach resulted in the actual preservation and rescue of Remac bundles, the protective structures that envelop healthy unmyelinated axons. Electron micrograph data proves this rescue. Subjects treated with an inert vehicle show fragmented, degraded axons, while those treated with topical XIB4035 maintain tightly packed, structurally intact nerve fibers. Topical positive modulation achieves true disease-modifying structural preservation without incurring systemic risk. The therapeutic effects of this local skin preservation extend far upstream into the central nervous system. In advanced small fiber neuropathy, the central non-peptidergic C fiber projections, the nerve wires that carry signals into the spine, begin to physically decay. Researchers track this central decay by targeting IB4 positive terminals, specific nerve endings located deep in the dorsal horn of the spinal cord. Histological data for the vehicle-treated control subjects reveals a complete absence of these fibers. The physical circuit into the spine is broken. But in the mutants treated with topical XIB4035, the data shows a robust, visible restoration of those central projections. By treating the distal nerve endings, the topical modulator provided enough tropic support to rebuild the neural circuit back into the spine. Shifting pharmacology from systemic agonists to localized positive modulators offers a viable blueprint for physically reversing small fiber neuropathy.